Right, as we are gone past 10 o'clock, we'll make a start. Good morning, everybody, and thank you very much for attending today. As I said, I'm Councillor Richard Siddle. I'm leader of Malton District Council, and I'm also the lead for Member for Health and Wellbeing at Local Government East. Thank you for attending. Today we're joined by members and officers from local councils across the East of England and colleagues in NHS England's regional teams and integrated care boards, the voluntary sector with all an interest in neighbourhood health. As you join, please feel free to add your name, role and organisation in the chat. Local Government East is a cross-party membership body of the 50 local councils and one combined authority in the East of England. The purpose of today is to consider how can innovation bring local government and the NHS together to improve health outcomes in deprived neighbourhoods. The discussion will help inform an article being developed by Local Government East, the NHS East and Health Innovation East, and why neighbourhood health matters in areas of high deprivation. There will also be an opportunity to ask questions after all the speakers have spoken. I would just like to introduce these speakers that we have today. So talking about policy landscape for neighbourhood health will be Phil Hope, former Minister of State for Care Services and co-chair of the Health Devolution Commission. Innovation in neighbourhood health and conversation into action. Piers Rickett will be talking about that, Chief Executive for Health Innovation East. And then the final part will be learning from National Health Neighbourhood Health Implementation Programme in Colchester. And that will be with Alison Armstrong, North East Essex Alliance Local Place Coach, and Rory Doyle, Strategic Director from Colchester City Council. If you can ensure that when you get to the point where we ask questions, we will then control that, and there'll be an opportunity later to talk about your ideas and your points of views. The slides will be shared with you after the event, and a recording will be available for all member councils. I'd like to thank Health Innovation East for kindly sponsoring today's roundtable. I'd now like to hand over to Phil Hope, who is a former Minister of State for Care Services and a Commissioner and lead author for the Health Devolution Commission, an independent cross-party and cross-sector body working to champion and support the successful implementation of devolved and integrated NHS public health and social care services across England. Over to you, Phil.
Richard, Councillor, thank you very much indeed, and good morning everybody. It's an interesting day upon which we're holding this particular seminar, and particularly obviously after the recent local elections. I was a former councillor myself, as well as being an MP and Minister of State for Care Services, and I've been working on the Neighbourhood Health Service agenda for some while now, working with some local council health and wellbeing boards on developing the conditions for their success in carrying out the new role that they will have. Say more about that at the moment. I'm working with a group called Health Integration Partners to help do that as well. I've been asked to do a quick overview because we're going to get some real on-the-ground substance from our subsequent speakers. So I'm going to take us through a bit of a gallop, if that's all right, on what a neighbourhood health service is, covering a number of themes. So Matt, if you could go to the next slide, please. So first of all, let's just think about where all this sits. And essentially, the government is undertaking a pretty fundamental redesign of the whole health and care delivery system to tackle what we all know and experienced: fragmentation, it being too hospital-centric, not end up being put into prevention. Although a huge amount has been done, that nonetheless, as we found out from Aradaz's review back in 2024, is a real problem. And the whole idea of the left shift of shifting services and resources from hospitals to community, from treatment to prevention, and being more proactive rather than reactive. And all of this neighbourhood health work aligns with the 10-year health plan that you'll all be familiar with. So it is really quite a structural reform of the NHS. It's a very a new thinking for some people in the NHS, obviously not so much in local government, about having a place-based operating model that emphasises the joint working both within different parts of the NHS in the community and between the NHS in its various shapes and forms with local authorities, including social care, public health, and so on, and of course alongside the voluntary sector. So that's the background that this whole initiative, which is a new operating model for the NHS, is working. Next slide, please. It's worth saying that this approach, this place-based approach, is only part of a wider place approach that the government has been taking across different government departments. So within the department, obviously, we've got ICBs, which have larger footprints, and they're being reconfigured as we speak, down from 43 to 23. Quite short the number is at the moment. The idea of advanced foundation trust. These are hospitals that see themselves as place-based anchors in terms of how they operate. Obviously, the unitary authorities with their health and wellbeing boards playing a leading role in the new system, and the idea of neighbourhood health services themselves. And of course, over at the Department for Housing, Communities and Local Government, we also know we've had the English Devolution Act, the role of mayoral strategic authorities, and that includes public health, by the way, and of course unitary councils with everything that you do around developing the places that you represent, alongside some local government funding reform, as well as a 3-year settlement, but some reshaping of where some of that money goes. And probably just worth saying that this all takes place against the background of public service reform. I mean, back in the day when I was a minister, total place thinking was very much in its at the start, and we were doing a lot of work around place-based budgets then. But more recently, we've just had the announcement of the Pride in Place strategy, and some of you on the call were receiving this extra money with new neighbourhood boards attached to them. We know about the Community Wealth Fund, and of course, there's a whole raft of new things happening around housing growth, New Towns Task Force, regeneration. And I suppose the real challenge in putting all this out is to say, hey, there's some consistency about a place-based approach from different parts of government, but when you receive this at a local level, you've got to join up the dots between the different bits of neighbourhood health services, neighbourhood boards for pride in place strategies, place thinking, how you relate to mayors and so on. So there is a job of work to be done locally to sort of link all these things together to make it a coherent whole. But that actually is what local government is pretty familiar with doing. And even though some of the geographies, and I'm going to say a bit more about geography, are different in different places, putting those together into a sort of coherent plan across different geographies of wards, of health services, of other ways of thinking in a place-based way, that is the job of local government. It's a job local government has done for many years. But I think it's both good news that it's happening in that way. It's a challenge to make sense of it in a rational way at a local level where it varies from place to place. Right, well, let's plunge into the next bit, which is so where does neighbourhood fit in all of this? So it is the reorganisation of services around defined local populations, and the sort of the basic single neighbourhood health service population side is 30 to 50,000. That's very much an NHS way of thinking about a place, is they think about a population that they serve. But all of them will be seeking to have these features: care closer to home, or indeed care on the high street, trying to integrate the various providers of health, social care and public health interventions and services, and within a neighbourhood health service, a range of NHS services, which at the moment may be operating in a siloed way, but in future should be operating in a much more collaborative, indeed, collective way, which includes general practice, the community health side, mental health, indeed, some diagnostics and some outpatient care, depending on the size and the geography. And all of these neighbourhood health services will have specific aims that they're trying to achieve. So it is about obviously improving health outcomes, but also about reducing health inequalities. It is about joining up the care. It is about trying to reduce pressure on hospitals. It is about trying to eliminate some of the duplication and inefficiency of these various parts of the system where everyone's bumping into one another. And of course, to deliver the constitutional standards with the NHS. So some of the design principles that are in the guidance that has now been published, there's a neighbourhood framework that many of you now will have been seeing, very clear It's about integrating. It's about more on prevention. It's about devolving power down to as close to the point of decision making as possible. And key aspects of that, there has to be a population health management. If you start with a population of 30 to 50,000, you need to know that population, what that population's health is, where the priorities are, where the challenges are, and that drives your priorities. And also a whole digital first. I haven't mentioned the shift from analog to digital, but it's another aspect of the NHS. I think it's an aspect of all of our lives as we're beginning to realise the power of the digital approach, and that applies to all aspects of both frontline care, but also back office systems that neighbourhood health services will start to develop. Think about electronic patient records. And all of that, including engagement with the community and co-designing with the community. Now, there's a debate about what the community is, and then there are various different kinds of communities that we talk about. There's place-based communities, obviously, but there are also communities of interest. So that challenge, something I think local government is very familiar with because it sort of informs exactly what local government is all about. But if the NHS can be going beyond, as it were, just patient voice in its approach. So a bit of a shift of culture, I think, for the NHS to move to a place-based approach which engages with people in a very positive way, as distinct from thinking about organs or diseases or conditions or those kind of things. All right, let's move to the next. How do we know we've been successful? So the government's national framework sets out some clear national goals, and it has identified that it wants to improve health outcomes for some national priority groups. And there are 4 of them: frailty and end of life. So that includes dementia, for example, people with multiple long-term conditions, and we're thinking there about people with perhaps in later life, but also working age adults who have got multiple long-term conditions, including physical and mental health conditions. Children and young people as a priority group, and cancer, people at risk of and seeking to prevent and reduce the impact of cancer. So as well as those national priority groups, of course, each area will identify its own local priority groups. So there will be those priorities that each neighbourhood health service will look at. But in a local area, there may be other particular groups because of your population health analysis that might emerge as well. You think about particularly adults with learning disabilities might be something that emerges. It might be travellers in the Romani community. It might be any other minority ethnic group in your area. It might not be a minority group at all. So that is based on the local data, including in particular something that local authorities have produced for many years, the Joint Strategic Needs Assessment. So as well as those priority groups, other national goals, improving GP access, that's definitely something that neighbourhoods have got to get better, to improve the planned care that people receive, improve urgent and emergency care in their patch, and to see improvements in patient satisfaction and staff satisfaction. So those are some of the boxes you've got to tick to be a successful neighbourhood health service, and some of them are pretty profound. So they are both health outcomes and health process measures of success. Okay, let's move on. I just wanted to highlight some other, again, I'm sorry I'm galloping through this, but it's an overview. It's intended to sort of set the scene. In terms of leadership of neighbourhood health, I think we need to think about this in different levels. So ICBs are responsible for commissioning the neighbourhood services, but they do so on the basis of a plan that's been produced by the Health and Wellbeing Board. And that's a very new role for Health and Wellbeing Boards, who in the past have met quarterly in the council chamber to sign off particular strategies that are presented to them, usually by either the council or by the local health partners, the ICBs, perhaps. But this is different. This is taking a leadership role in developing a neighbourhood health plan and having to think through that task that I mentioned at the start, which is, so what is going to be the neighbourhood health service geography or footprints for our patch? And getting that developed is the task of this year, developing both the skills to do that and then to have to produce that for 2027. And of course, within a neighbourhood health plan, there will be a description of what all the neighbourhood health services will look like, what their footprints are, who's involved with them, but they will be led each of those by GPs and or local authorities, so that a neighbourhood service leadership, and certainly the clinical leadership will be mainly primarily coming from GPs, although there are some exceptions to that I'll mention later. And we'll be hearing from one of the 43 pilot areas. So to back all this up, there is a neighbourhood implementation plan. And the 43 pilot areas are all trying out different ways of tackling those goals and putting those resources together. And so and that lessons will be learned and then shared. So just some of the core components, just for real clarity here. So every neighbourhood's health service will be expected to do population health management, analysis, and dealing with the health of the population in its broadest sense. They will have to have modern general practice approaches, standardise their community health services against good practice. Each one will have integrated neighbourhood teams. I think it's worth saying about integrated neighbourhood teams in particular that doesn't mean there's one integrated neighbourhood team. There will be within a neighbourhood health service, you might have a team of people from the voluntary sector, from the local authority, social care, obviously from the NHS and different aspects, working together around, say, frail and elderly people. But that will be a different neighbourhood team will be needed for children and young people. So those neighbourhood teams isn't like one fixed group of people inside the neighbourhood. It's putting together the right people around different cohorts to achieve different health outcomes. So those teams are a critical part of the system. It's expected that there will be some home first services, rehabilitation spelt out, people know what's going on, how it works, and urgent neighbourhood services too, maybe rapid response services or virtual wards. And given the size of the neighbourhood, there is a question at what level all this happens. Now let's move to the next slide. I just wanted to mention these, I call them enablers. I know that nationally the importance of the estates and how those neighbourhood health centres, everybody developing neighbourhood health centres in their patch, is seen as being fairly critical. It's where different services can be co-located, different health services, social care, public health perhaps, a voluntary sector inside a centre, a building in an area. So the investment goes into either the existing estate or to new build. And I've put the words location 3 times there, because where that neighbourhood health centre is located sort of indicates, does it really reflect the model, the new operating model? If it's just a beefed up GP surgery located outside the town, that doesn't feel like it's at the heart of things. It doesn't feel like it's got co-location of all the other organisations. It doesn't sound like it's got that sort of reflection. Whereas if it's taking over a large empty shop in the town centre and putting a range of services in there, then that starts to look like what a neighbourhood health centre might look like. That's for a lot of discussion and a lot of debate, but I'd chuck that in as a bit of a provocation. There will be changes for the workforce because people will be expected to work in multidisciplinary ways and potentially new roles and career pathways. And just to be clear, this point about size and geography, there will be single neighbourhood providers, an organisation, a group of people led by a particular perhaps a GP primary care network at 30 to 50,000. But there may be some in which there is a multi-neighbourhood provider. In other words, they cover, say, 5 or 6 different single neighbourhood health services, but run by one organisation. And the biggest form of that is, and there may be a few of these, integrated health organisations where the whole population budget, the whole budget for health, acute as well as community health and GP practices, is taken over into one and run and led by one integrated health organisation. And the question there is, who's going to be the integrated health organisations? Is it just going to be the large acutes because they've got obviously the huge budgets and therefore they take over everything else? And is that a problem, or is that a solution, or is that a problem? And I suppose lastly, that point about finance. I mean, there will be some new money to oil the wheels, as it were. You think about the money that GPs get for their primary care networks, that will become reshaped into neighbourhood health services. But this isn't another programme with a number of money. It's not like another layer of icing on the community side cake. This is rebaking that cake, not So it's more like, and a bad analogy this, but pouring rum through the Christmas cake to change its flavour throughout, not just a layer of icing on the top. So you'll see outcome-based contracts as a feature, risk-sharing models in terms of finance with other partners. Okay, I've put the next slide in just to sort of give some sense of, well, it helps me anyway to think of this as in geography terms. So the place might be the size of a unitary authority, or an acute hospital footprint with its anchor role. And then the multiple neighbourhood size, the sort of 250,000 could be this, is where you might see a community diagnostic centre or your urgent community response kind of led and organised. Then everybody has a neighbourhood in which there are these integrated neighbourhood teams, maybe a health centre, lots of coordination, integration, and for children and young people, family hubs and clusters. And then at the locality level, within inside a neighbourhood service, you might have GP practices, community anchors, smaller organisations, the voluntary sector, link workers, and so on, who are visible and present in all those levels, but that's where the action really sort of happens. And of course, in people's homes is the lowest part of the place, or the most closer to the people, where healthcare is delivered in people's homes through domiciliary care and the social care system, virtual wards, where befriending and carer support and so on might actually happen in practice. So lastly, and I hope I'm not spending my time too much, some challenges. So for me, and you may have different views about what I've just said, but some of the challenges I see is there's been this debate going on. Is this an NHS neighbourhood health service, or is it a non-NHS NHS doing other things other than the traditional NHS and improving the way the NHS works? Well, in my view, that's a sterile and pointless debate. It's both. We've both got to improve the way the NHS operates, and we've got to recognise that a lot of the things that the neighbourhood health services will do are not actually delivered by the NHS. If you're going to improve people's health, you're going to be doing public health, you're going to be doing social care, you're going to be doing integration. So it's not worth having the debate, really. Just assume you're going to be doing both, and then you've got to work out your priorities and how to do it. Certainly, in terms of explicit inclusion, social care has to be there as equal partners. And local authorities, of course, lead on public health as well, with shared outcomes. And in social care, not only do the commissioners, the local council, but providers of social care, providers of public health need to be in the room as well, and playing their part in delivering those outcomes. I've mentioned the geography now. How do we get these coherent footprints of the inheritance of the primary care networks? This idea of single neighbourhood partnerships and multi-neighbourhood partnerships. That's got to be worked through place by place, area by area, to get it right. And referring right back to that earlier strategic point, there's these other wider alignment of other pride in place and other place-based neighbourhood approaches that many councils are very familiar with, but perhaps the NHS aren't and need to grapple with and understand. The importance of the estate strategy that reflects the new operating model, I really do think that's a key kind of indicator. If you can say my estate really does, where we're putting the money really does reflect that new operating model, then you're moving forward properly, as opposed to just giving a bung to one or two building improvements here or there. And we got to get on with it. And this is the point of the 43 pilots and the learning, building on works already, because a lot of what I've actually just said is not particularly new. I mean, people have been doing this to some extent in different places at different levels for years. But this is now the new operating model. So we want to build on what works and generate those quick wins to create the momentum. And as ever, all of this relies on good relationships at all these different levels between the ICB, the health and wellbeing boards, the council, the providers of the neighbourhood health services, the acute trusts. Crucially, I don't think you can deliver neighbourhood health services without meaningful engagement of the voluntary sector. They're not just an added afterthought. They've got to be central to the process. And ditto, people with lived experience. And those of us in the local council social care world are very familiar with concepts of co-production, not so familiar with the NHS. And within the NHS, I do think the GPs and the hospital consultants have got to sort themselves out, because we've got to see this as not being a battle between the hospital and the community. It's got to be a collaboration with the hospitals making their commitments to make this neighbourhood approach work. And lastly, I think it's all about applying the learning from the pilots. How are we going to do that? How do we not reinvent the wheel in every area, but really gain the best we can from areas that have similar circumstances? Kate, I think, or Richard, sorry, I'm sorry if I've gone over my time, but I wanted to take
Just a
us
little
through
bit, Phil. Just a little bit.
just
We'll let you off.
gallop us through and it's there as a start of a tent for a discussion.
Okay, so I've noticed that there's some hands up and some questions and some hands up. We will go through all the speakers first, and then there will be a question and answer session. So if you, I know some people have put questions in the chat, but we will come to that later, and there will be also an opportunity for sharing ideas as well later. So if you do have a question, please make a note of it or put it in the chat, and we'll come to it in about 15-20 minutes or so to do that once everybody has spoken. I'm now going to hand over to Piers. Thank you.
So good morning, everybody. Piers Ricketts, Chief Executive at Health Innovation East. I hope you can hear me all right. So if you can't, so our role, our core funding comes from NHS England and the Office for Life Sciences to support the adoption and spread of innovations in health and care. And congratulations to Phil on that whistle-stop tour of all the policy landscape. So what I'm going to try and do is make sense of that and show a couple of examples where communities are starting to make sense of this and doing things differently as a result. So if I can just find my slides to share, bear with me a minute, please. There we go. Can you see that? Yeah, is that all right? Okay, great. This is obviously I can't see you when I'm presenting, so Richard, if anything happens, do shout out. This is a well-trodden path, isn't it? The concept of neighbourhood health, with the NHS, local authorities and others working together. And we've seen a number of different policy initiatives. So the Better Care Fund, for example, has been with us a while. A couple of evaluations there which show that the success has been mixed. Some of the comments you'll all be familiar with. Was this simply a way of getting services to be delivered that needed to be delivered anyway, and people couldn't find the original budget? So a lot's been happening there. And of course, much of the recent policy work that's just been described by Phil comes from the Department of Health and NHS England, because obviously that's where healthcare is funded. But as Phil was just saying, this is all about the various different parts of the public sector working together to make it happen. And how do we do that, as opposed to trying to digest the huge amount of guidance that's come over in the last year or so? And I guess the key document there is some policy that was issued in March or April time by NHS England that set out for ICBs and their public sector partners the things that they wanted to see happen over the next 3 years. And there is time to start doing this. But I think what this kind of policy work tends to underestimate is the huge amount of practical action and practical implementation that needs to happen if we're to bring these very sensible policies to life. So in my organisation, we've tried to find evidence of where innovations in technology infrastructure have supported more local models of health and care. So where's the evidence? What are the examples where we've got better results for people, patients, and workforce? And there are a couple of examples I wanted to take us through now. Sisu Health, I noticed that Jez Ellen-Stiles from the company is on the call. So this is the left-hand picture there, the health station, which I think above all enables people who aren't regularly in touch with their local practice or local health services to have a health assessment in places like they might be cancer services buildings, they might be homeless centres, which I think that one there is from, and in many workplaces. And then depending on the result, be put in touch with the GP practice or other local services. And the other one there is My Happy Mind, which is doing fantastic work in schools, often commissioned by health and local authorities together, or indeed by from education budgets, to support resilience and mental health. And there's some really good data there producing about the numbers of children being reduced who might need SEND support, referrals to CAMS, or numbers of school exclusion. And you can track where the programs have been introduced in schools compared with the typical rates of those children needing SEND, referrals to CAMS, and school exclusion. And you can, whilst correlation is not necessarily causation, you can track the beneficial results of that. So things, point solutions, you might say, starting to happen that bring some of these concepts to life. But it's early days as yet to see a whole system that's built on the principle of truly shared services and founded on shared data. So I think we'll talk about a couple of key principles and enablers, and I want to showcase a couple of examples where this is starting to happen. So our work has shown that neighbourhood health is still, in the way that sort of Phil describes it, is still embryonic. There isn't a clear definition of how you make this happen. And obviously you've all got existing community-based and place-based teams delivering health and care, which already align with that ambition. But the new part is how's it being brought together? And focusing on individual innovations or teams isn't particularly helpful, but actually we need to look at the data and the infrastructure and how we make this happen. And there's an interesting project we've just been commissioned to undertake by the British Heart Foundation. This is a national project to understand how neighbourhood health approaches can strengthen cardiovascular disease prevention and better management. And obviously there's a clear link between deprivation, whether it's health deprivation or economic deprivation, and numbers of people with CVD, cardiovascular disease. And obviously CVD is still the biggest single preventable cause of early mortality. And what BHF wants to understand is there a way that effective neighbourhood health provision looks like for people living with or at risk of CVD? And we just started looking at the evidence. The project's going to run until November. And a couple of early findings, we can share the slides, you can look at the links on the website. But there are a couple of early emerging examples where communities are looking at this. So in Hillingdon, for example, there's some neighbourhood hypertension work using shared data. And the key enabler here is the shared data between social care and GP records and a sort of what they describe as a tell us once approach, because we all know the feeling, well, we've narrated our condition or our relative's condition to all the different actors in that person's care. So in this case, it will enable multiple clients to input into the GP records directly or indirectly. And in Lewisham, there's some really good integrated neighbourhood teams work, which do combine the multidisciplinary team care coordination with community co-design and local communities being very much involved with the design of those services. So what those two examples are already starting to tell us is how digital infrastructure and data sets will be developed at the neighbourhood level. And we hear a lot talked about the shared care record, the issues around data sharing. It's not particularly sexy, but this is one of the absolutely key indicators, I think, to making that happen. So I think it's all about enablers, infrastructure, things you can do differently, perhaps remembering Hilary Cottam, those of you who are familiar with Radical Help and the Wigan deal. What Hilary Cottam said is, we often think in the public sector that changing the service is just changing the way in which they're managed and directed. And of course it isn't, but that's often the perception. So that's a good place to start from. And where I wanted to finish in a bit more detail is a case study from West Hertfordshire. And I've just seen that Ros Nerio from the NHS in Hertfordshire, who helped on the commissioning and leading of this, is in the audience. So Ros, I hope I get the details right. But I went to the launch of this last September and was really struck by the ambition and the way they're setting out to do things differently. So I thought it was worth spending a bit of time on this as a sort of final example. So, and maybe in the Q&A, there'll be quick questions for Ros as well, because you know this much better than I do. But West Hertfordshire Neighbourhood Integrator announced last September a big launch event at Watford Football Club. And Macmillan, the cancer support charity, has committed £10 million of investment into a model of care which supports proactive, risk-based care for frail elderly people at high risk of hospital admission or adverse outcomes. So in a 3 or 4 year project, this is going to be looking at selecting 500 patients a year, ultimately across, I think, 4 wards. And there are 3 core elements. So there's a multidisciplinary team in the community that focuses on preventative care run by the current community services NHS provider. And then the really interesting bit is the community interest company, which is being set up with all the local service partners as members. And the way the finance flows work is that the benefits of the reduced hospital spend on which this is based. So often we assume that community spend is cheaper than hospital spend. It is in theory, it's not always proved, but they're actually going to look at the data and hopefully prove this. And the surplus is then to be reinvested back into the neighbourhood teams. And then underpinning all this is a grant-giving enterprise that supports grassroots and voluntary sector organisations who do a lot of the preventative community work that ultimately delays people escalating and progressing towards acute admissions. And there's lots of really interesting things about the partnership. The use of data to identify the 2,000 patients most likely to benefit, the linking of payment for services through social finance, only when there's a demonstrable reduction in acute hospital spending, and perhaps most relevantly for us today, the role of the South and West Herts Health and Care Partnership, which explicitly brings together NHS, local authority, and the voluntary and community sector partners to design and deliver these services. And at the launch event, it was really striking how many of those community partners were there. So this is getting national attention, and it's early days yet. It's a 3 to 4 year programme, and I think it'll be a while before evidence on benefits and outcomes will be available. But I really love the way in which they've combined an innovative finance model, neighbourhood teams that were already there, but sort of aligned the community design. They've gone out to people and said, what do you want in this particular ward of West Herts? How do you want these particular services to be organised? Who's best to provide them? And in many cases, it's the local voluntary groups, and managed to put all that together in the design of the model and the contract. So I think this is really, really exciting. And there are national teams looking at evaluating this and seeing how it works. So I think it's early days in making this happen, but I think in many cases, as we said, the different teams are already there and already set up. But what else do we need to do? How do we line incentives? How do we get the best out of the community and grassroots groups who are often at the heart of this, and enable teams to probably work together to bring into practice what I think can seem an intimidating amount of guidance that's come out from the NHS. Happy to take questions later on, but I will stop sharing there. Thank you very much.
Thank you very much, Piers. Very good. So I'll now hand over to Alison and to Rory to do their presentation.
Good morning, everyone. My name's Alison Armstrong, so I'm commonly known as Ali, so please feel free to call me that on the call. A little bit about me, not nearly as enlightening as Phil's introduction, but I'm a nurse by background, trained, it feels like 100 years ago, but I've been a director in both health and social care services for a number of years, both at commissioning and at provision. I live in Colchester, and I have been here as long as probably I've lived in Scotland, but I've still perhaps got my accent a little bit. For the purpose of this event, I'm the local neighbourhood and place coach for North East Essex, and we just wanted to tell you a little bit about the programme that we've got in North East Essex currently. Next slide, please. So our neighbourhood journey is not just a new one. In North East Essex, I think those of you who know the area know that we've had a really strong foundation in terms of neighbourhoods and place and alliance partnership for a number of years. In 2021, we began to think really about how we could work more closely together. System partners always lean in and work together. It's not just about the NHS or social care. Our local councils have been leaders in much of this work, along with our really strong voluntary sector, and it's very humbling that they both hold us to account and lead the way with many of the innovations we've taken. One of the inspiring things that really pulled us together was Professor Marmot, when he came to talk to us about the wider determinants of health. And we really thought about this in North East Essex and thought, well, this is what we believe in. We know it's not just about whether it's physical health care or mental health care or social care. We know that all the constituents of the wider determinants, including health, housing and education and employment and inequalities, is really fundamental to the way we think about how we think about neighbourhoods now. So we began that journey, and we've really transitioned, as we've said, into the place-based system. We've thought about how do we really focus on this collectively together. I think it's safe to say we've had several attempts at working in a neighbourhood way, and for many people across the country, the traditional way is to think, well, let's throw everything at the kitchen sink at this, or why don't we just put health and social care teams together? But for us, we didn't feel that was really what we wanted for our neighbourhoods. So we wanted to think about how we could test some of this in terms of focusing on the community, and we've heard about innovations earlier that other areas across the country have focused on. We wanted to really focus on target driven and use data and population health management. We were lucky enough to work with Newton Europe, an external company who really helped us to focus on cohorts. And surprisingly, we didn't just come up with, we need to look at frailty and end of life and perhaps some of the physical conditions. It really focused us and reminded us that we do need to talk about the wider determinants, that many people and their families attend all services, not just because they have a physical health complaint or because they need care, support from social care or from the voluntary sector, but they have complexities. And much of that is caused by the way our services are both provided and commissioned. It's very much focused on the individual. And as a nurse, while that's admirable, we know that it's either the whole household or the whole family that often supports a multitude of things, particularly behind closed doors. We also began to think last year about how we are going to set up neighbourhoods, because we were getting very close to really thinking about this. At the same time, as mentioned earlier, the National Neighbourhood Initiative was launched, and we were selected as one of the 43 sites to test and learn from some of the work that we wanted to do, which were whole household, wider determinants of health, all age. And so we put our submission in, and we were one of the ones selected. And I have to say, I know we've got regional colleagues on the call, but they were fantastic at supporting us in terms of being a bit braver and a bit bolder and not focusing on one particular condition, because we felt that our partners, all our partners, strongly felt that it wasn't just about that. So we're now working through our test and learn. We've had the first, if you like, iteration of that. We've got some learning from that, which I'll share with you in a moment. We've heard earlier that we also have a number of other initiatives, and Rory's going to talk about one of those later in terms of our neighbourhood health centre models. But again, we believe it's not something that needs to just be physical. It can be virtual and hybrid, and we can share across areas, because we're not going to suddenly develop diagnostic centres in every town in North East Essex, but we are a really sharing alliance and a sharing organisations, and I think that's one of our strengths. Rory, if you could go to the next slide, please. We also wanted to talk to you about the governance for this, because we hear a lot about top down or bottom up, but we decided again to be a little bit different, because ours is about a continuum. How can we be top down or bottom up if we don't put the person and the family and the household first? But also, how can we not bring in leaders and to influence the individual organisations and services? And how can we not learn from the neighbourhood teams that are emerging now and our primary care networks? So this is our governance, and hopefully that will reflect how we think and how things drive each other. And our voluntary sector here are a fantastic source of support to both person and family to make sure they've got a voice. We also wanted to think this isn't just about inequalities, and as one of my colleagues who happens to live in Jaywick, she didn't want us just to think about Jaywick as she called it a deprivation destination. She wanted to use the learning from there, but also we know that there's deprivation and inequalities across all systems and across all of North East Essex. Next slide, please, Rory. We have tested, as I said, the neighbourhood test and learn, which was part of the National Neighbourhood Submission. And these are some of the things that we've learned. We'll share the slides, and I do apologise for the writing being small. We also are fortunate enough to, at the same time, to have had 3 pilots, national pilot sites, which is Colchester Medical Practice, PCN, Tendring PCN, and Ranworth PCN, which is in the Clacton area as well. And along with those, we've taken the learning from all of them to really shape our neighbourhoods. And what we've learned, as I've put down in the corner here, is that proactive care takes many forms. Yes, it is about frailty identification, and I don't like to use the word high system users, because actually it's actually people that use our systems are perhaps the highest users, because the systems that we've created are hardest to navigate. So there's something for us about thinking about that as we've gone along, in terms of how we change those words and think about, if people are using our systems to a great degree, is it because they're not getting what they need from us, and can we regroup in a different way to think more proactively for them? Whatever we do need not just acute and primary care. We need multi-agency and multidisciplinary approaches. For us, it's about building those relationships, about thinking proactively, and not just thinking in a reactive state, which many of our services are currently. And it's about improving those outcomes. And we heard earlier, there's national imperatives, but for local people, it's for all our local people, not just the ones that are on the highest priority. Next slide, please. As we've heard earlier, these are some of the things that the national neighbourhood teams have mandated us to do. And we wanted to really think about that. And as I've said, the voluntary sector and local authority partners for us are fundamental to this, and in fact have driven a lot of the innovation thus far, not just health services. But we also wanted to think about, again, how we move from routine care, proactive care, and think about that way that is actually established in our communities. And let's not talk about enabling and empowering local people, because what they tell us is they're already empowered. It's our services that disempower them. So how do we allow them to retain that power? Next slide, please. So for us, the two key things that we're embarking on currently are developing neighbourhood networks, and I'll talk about that a little bit more in a minute, but it's about that service alignment. So I put down some of the key features, but some of it is really about hardwiring local services to work together. And everyone said, oh yes, we all work together, but we do that through referrals rather than leaning into each other and having what I'd call warm handovers, and making sure that we follow up on people and we really notice the whole household. We don't have coordinators at the minute, which we're looking at, and we don't really think about the wider determinants of health and pulling in those networks. We have a fantastic service called Frontline, which is commissioned locally, which has really helped us think through how people, local people and services, really understand what's available, because I think some of the time we have really noticed that it's about not being aware, and if we're not aware, sometimes we just ignore or not notice. We are aware that we do want to develop neighbourhood teams or multi-agency teams rather than disciplinary. We recognise that it's not just about health and adult social care coming together, it's about a whole system approach. And if I go into the next slide, we can talk a little bit about that. For the neighbourhood networks, what we want to think about is know what we need to do, know who you are and how to contact you, build trust and relationships, and really improve that working together. And we've come up with an acronym, which is Think Place. And Place for us is about every neighbourhood partner, whether you're in someone's home or you're meeting a family, in whatever setting, that you think about physical health of the whole household, their living situation, are all their needs of the household being recognised and supported, and not just seeing the individual in front of you. Connections and social context. We know that many people have different forms of isolation or lack of connection, and for many young people, the reliance on AI and virtual has become habitual. We know that emotional and mental health being isn't just about whether you're mentally ill, it's about all the degrees in between. And many of the people that were identified with Newton Europe in our cohort had low-level anxiety, depression, and isolation. And that was one of the main reasons they were accessing services, because they didn't feel they were getting what they needed from the current presentations. Next slide, please. And these are our neighbourhood networks. So as you can see, these are all the partners that are in our system, in our alliance, that we work very closely with, that we really want them to think place. And we've had fantastic support from both leadership and operational teams already. We're going to have an event in early June at Colchester Rugby Club, where many of these partners will come together, not just to get to know each other, but to really think how we're going to get them to think place. It's not an easy task, because as I said at the beginning, many people in their training and in their assessments, it's about individuals. So it's about hardwiring everyone to really think about that whole neighbourhood network and the whole household all age approach. It's not just for the local operational teams to do. I think they are going to be the easy part. Sometimes it's how services commissioned and led. And while we've got a fantastic alliance and neighbourhood programme board, it's all the people in every organisation that we have to work on to get them to think, how do we think neighbourhood and think networking? The other part, as I said, that we're focusing on is smaller multi-agency teams who will work with local households, local families on those wider determinants, and these will be identified by the neighbourhood networks as perhaps people that have got greatest complexities because of the way services are provided. The core teams will be mental health and wellbeing, social care, both adult and children's services, social prescribers, some from primary care and some from the voluntary sector, and community health services as the main cohort, with primary care leaning in as required, and also again housing, hospice and voluntary sector wrapping around in that wider sense. Next slide. And this is just the areas to remind people that we're thinking about, and the networks and the neighbourhoods that we'll be working in. But as we heard earlier, neighbourhoods might be a geographical construct, but we also want to think locally about whether it's specific services for a cohort or whether it's for an age group. And we will develop services and construct services to move around, because going back to the governance slide when we heard about local people and what they want, the key things for us that they said were they want to be able to come to a service, tell their story once and have that support. They don't want to be passed from pillar to post. They don't want to be referred on and have to wait months for services. And they don't want to then be, if you like, assessed as complex or assessed as actually demanding, because it's us that perhaps is not delivering and supporting them in the way they needed. And most of all, they want to be in charge of their own services and support. So I think for us, hopefully you'll get a flavour of that. I'm now going to hand over to Rory to talk about the Heart of Grinstead and some of the other exciting developments in our area. Thank you.
Rory, before you
I was
start,
going to say, I was going to check in with you because I'm mindful I'm probably very short on time. So I'll take my lead from you, Chair.
Can you do it in 5 minutes?
I'll do my best to pick out some key points.
All right, thanks,
and so
Rory.
Good morning, everybody. My name is Rory Doyle. I'm Strategic Director at Colchester City Council. And I wanted to talk to you more specifically about neighbourhood health with an example of Grinstead, and actually position this actually as give a view from a council perspective, navigating the NHS world, and as a stakeholder in our kind of place-based partnership to neighbourhood health in North East Essex. I won't dwell on this side this was context in terms of Grinstead, and look, you will all have areas in your districts and in your councils that aren't performing as well as others. And I think for me, there's something here about scale versus locality. On the scheme of things, Colchester as a place is doing pretty well, actually. But if we don't delve in and go deeper into communities and places and understand them more effectively, we will lose sight of some really deep and stubborn inequalities that exist. And that's been, you know, been the issue with Greenstead for some time. I think there's also a recognition of how we need to turn up differently and work with places. I think with good intent, we've tended to parachute in, and I mean the NHS, I mean local councils, institutions and organisations generally, to try and fix places. And I think, you know, we recognise that there needs to be a different approach going forward. I mean, the key headline, I guess, from here: people in Greenstead aren't just getting iller; they're getting poorer. That's a social justice issue. You know, there's an economic case to this, so it's not just a health factor. What I would say in terms of Greenstead, so our work in Greenstead predates our involvement in the National Neighbourhood Health Implementation Programme. We were already thinking about local relational services in and alongside the community, both in Greenstead but in other places in Colchester too. Phil's already talked to the plethora of things we need to navigate as a local authority in terms of government programmes, government policies. Colchester and Greenstead have benefited from both regional and national programmes, and our work in Greenstead really kind of accelerated around the town deal investment that we received from government a number of years back, and that was about a capital investment in infrastructure and buildings. But I guess the key thing for us is, whilst that is the case, it was always about the model that sits behind it. It was all about the relationships in place and doing things differently. And I guess there's a question for us. If we're estate-led in our decisions around neighbourhood health hubs, etc., it's probably not going to work. This isn't just about refurbing buildings, extending buildings. It's not about co-locating services together. You know, we're all aware of services that might be co-located. Are they integrated? Probably not. Are they actively serving their communities better? Maybe not. So, you know, the model that sat behind this and the work that we've been doing has been all about relationships and creating the conditions as organisations and institutions to understand our communities better and work alongside them differently. And that's kind of just highlighted here, which kind of weaves together all of the kind of public sector offer that's available and how we want to bring it alongside the capacities, the capabilities, the strengths that exist in the community. You know, weave together both the formal interventions with the absolute abundance of informal networks and support that exist in communities. I will talk a little bit about buildings because this is what we're up to in Greenstead. And when we started, actually, we did have visions of a nice new shiny building, but actually, you know, escalating costs and funding doesn't go too far these days. But actually, I think what we've come together as a programme is something that's better because of it. And we're utilising existing assets. So Greenstead was always blessed with amazing community assets. It has a community centre, a library, a GP practice, you know, local schools, churches in a close proximity. And what we're proposing to do, and you can see here, is to extend the existing community centre, which is kind of the pink building on the top right, significantly increasing the footprint of that, so extending that out, redeveloping the existing structure, but alongside that will be a new library building, which is being relocated from the kind of yellowy orange building to the left. So we have a really great integrated library, community cafe, hireable space, real community-led area within the new community centre. The existing library building, that kind of amber orange building, is being redeveloped into a children's and families hub. So it will bring together services aligned mainly to providing support to children and families, but also there's nursery provision within that. And the blue building was an existing GP practice that took up an element of the footprint, which we've received funding to extend, and that work's been completed. So we've significantly increased the footprint of the GP practice. That's part of Abbeyfield PCN, which is one of our test and learn sites within the national programme. And we've also got a couple of floors above that, which is going to be our kind of integrated space for services. So our housing services and housing teams that are supporting people in Greenstead will be based there, alongside mental health services, social care, community and voluntary sector. So scaffolding to really support the relationships. Again, talking to Phil's point really quickly, we're trying to navigate a plethora of stuff. Tackling the causes of inequality has been a strategic priority for the council for some time. And we've needed to translate and make sense of all of these programs. And we've been deliberate at that. So it's all part of the same continuum, right? So they're all trying to broadly deliver the same things, which I think is what this this slide presents. But what we've done, and particularly to Greenstead benefit, is leverage the value of these programs together to make them better, because we align it, and it just makes it easier for us as well. Learning and reflection. So I will pause on this one a little bit, because I think it's been alluded to in the conversations we've had so far. Good health and well-being is created in communities and places. And we really need to pay attention to creation of health in neighbourhoods. And I would say this, I'm local government by background, but local government and the VCSE have a key role here. Sorry, NHS colleagues, but we do have a tendency to kind of fall back into clinical and treating and kind of approaches to things. So we have a role here. And local government as the health service really to kind of influence things. The learning we've had from all of our work is that the way we do things gets in the way. The way we design services, the way they're delivered, and what we measure as success can be part of the problem. So we really need to challenge ourselves to think differently on that. And a provocation, really, something for us to have a talk about, perhaps. What we measure drives the behaviour. What if we measured the health of a neighbourhood by metrics like hope, agency, purpose, and whether people feel safe in their communities? We know that all of those things are prerequisites for good metabolic health. And if you don't have good metabolic health, you have chronic stress, you have disease prevalence. So, these are key things. One of the key takeaways that I'll have, and I'll end on this point, Chair, is when I went to some of the learning events for the National Neighbourhood Health Programme, what I observed when I was amongst colleagues was brilliant innovation happening up and down the country. And really great initiatives, doing things differently to better support communities. But it seemed to be happening despite of the system and not because of it. People were having to develop workarounds, fudges. It's never whether that be how they make lease agreements on kind of shared estate to sharing data and et cetera, et cetera. It feels difficult, more difficult than it needs to be. We'll end just really briefly on the massive opportunity we have with change happening all at the same time. NHS reform, local government change, it's all part of the same thing. And if we're not careful, we're at risk of probably developing parallel delivery mechanisms. We've got huge opportunity if we do this all together. Chair, I'll call it an end there. I have whizzed through those things. I'll share the slides because there is a video that I wanted to share and we haven't got time for, but it's a really great example of health creation in a neighbourhood. And if people look at the video, it's about a free bike provision scheme we've delivered in Colchester, but it's been delivered elsewhere in Essex, including tendering. If you listen to the members of the community, what it's done for them in terms of hope, connection to other people in their community and giving them agency and how they feel about their place, we'll get a sense of actually what drives neighbourhood health in localities. I'll end there.
Okay. Thanks, Rory. So what I'm going to do is move to the question and answer session. So in terms of the discussion, what I've done is I've put the discussion topic into the chat. If you do have items that you want to contribute in terms of that, it would be really useful in terms of the report that we'll produce. So if there are, I know people have been doing that in terms of the chat already, sharing their ideas and putting forward their ideas. So we'll do questions, and at the same time, if people have things that they want to contribute around that topic, then please feel free to put it into the chat function. I am also going to be really strict in terms of your questions. Can you please introduce yourself, who you are, and then what your question is? No preambles, please. That way we can get through more questions. I'm going to start with Councillor Joe Rust.
Thank you. Councillor Joe Rust, Cabinet Member for People and Communities in the Borough Council of Kingsland and West Norfolk and Chair of the Health and Wellbeing Partnership. Partnerships haven't been mentioned anywhere, and yet at local government level we are already delivering these. This is very much focused on the NHS and primary care, when in matter of fact at a local government level, at borough level, not county council level, we are already successfully delivering this, and we are working to become
what's your
a
question, Joe?
So the question is, what steps are your organisations taking, which are very much focused on health, to reach out to health and wellbeing partnerships, not health and wellbeing boards?
Okay, thanks, Joe. Ian, your question, please.
Thanks very much. I guess it's a similar, Ian Davidson, excuse me, Chief Executive of Tendring District Council, which includes JWIG, and also Vice Chair of the County-wide Health and Wellbeing Board. And I guess my question is sort of similar to Joe's, is how do we change the approach by being, it is a holistic, it is about public services. It's not what are you doing about it, it's what are we doing about it, and changing that approach. So with district councils as an example, that's got it with Phil, who I've known for a long time, going back to Play Space, may not remember, so hi Phil, but it's going back to that kind of what is that contribution, and district councils actually do housing, local economic growth, and community safety, many things which actually affect the health and well-being of our people. Mental health hubs in 31 different primary schools, which have been introduced by district council, not by counties, and obviously the diagnostic hospital's got 150,000 people going through it. But that's all happened because of changing it about what are we doing about it. But how do we change our sector more widely to saying this is a whole holistic problem? It is not, this is health, this is local government, this is police, this is fire. Actually, what is a collective approach?
Okay, thanks, Ian. Who wants to go first with that one? And with Joe's question as well.
I'm happy to make a few general observations at space. I think to answer Ian's question first, and obviously I don't have the benefit of deep place experience that some of the other speakers have had, but my old boss used to say change is a human contact sport and the currency is people. And the fundamental driver of all of this, I think, is all your relationships as leaders in the public sector across different pieces of it. Because without effective working relationships, none of the really amazing things like you described in Greenston or wherever it is are going to work. And one interesting example, just one example in my own experience, Milton Keynes Hospital, where I'm a non-exec director, has for the last, I think, 6 to 9 months had members of the council's housing team in their discharge lounge, as well as members of the council's adult social care team. There's a rota, so there's always a mix of health and local authority looking at through who's going home or who's going to go home in the next sort of 3 days. What do they need? Can we make sure that the team has delivered in their home what they need so the patients can get back home, which is better for them, and the hospital can treat others. And seeing the guys actually in this sort of control room working together, I think, is a really good example. But those things don't happen unless people think about them. They do all the relationship work, trust that builds up, because ultimately you've all got statutory budgets, and that's what often tends to drive the behaviour. So I think that's the obvious thing.
Okay.
I think to Joe's point, partnerships, all the things that I was talking about in partnerships, and the various parts of the council local authority sector, whether district or county, I think it was more districts, were present at that Hearts event, so I think they were there, but clearly we can provide more detail on that.
Okay, I saw Rory's hand go up briefly before. So, Rory?
Yeah, thank you. I completely agree with you, Councillor Rust. I would say that in North East Essex we absolutely are a place partnership. That's certainly how we position ourselves. And hopefully you took some of what we shared, in recognising that we do focus beyond kind of health type interventions. And fundamental, I think Ali mentioned our think place approach, which is absolutely looking at people's living circumstances, their housing. We've done a huge amount of work on increasing levels of physical activity and the role that the districts and boroughs have in supporting that through our amazing green spaces, our leisure services. So I think we recognise the real diverse offer, and equally and importantly, going back to the point around the social and economic perspective, is around work and skills and our role to support people and families in that respect. And the other thing I would just add is that I co-chair our Neighbourhood Health Board with our Director of Adult Social Care in North East Essex. So it's not an ICB person, it's not an NHS person, it's local government. And again, I hope that gives us that ability to challenge in a good way when we feel we're getting a bit too NHS-y. So Ali, I didn't know whether there was anything you wanted to briefly add on that, but I completely agree with that view.
Yeah, I think it was just to say that hopefully the slides that we presented reflect that ambition, not to just be exclusively NHS. And I think that, as Rory said, having that leadership from both Essex County Council and one of the local councils as co-chairs of the Neighbourhood Programme Board, but more importantly for local teams, asking you all to get behind that concept of the neighbourhood networking and think place across all of the organisations that you've heard can really help us to support your ambitions as well. So it's not top down, bottom up, it is that continuum. Thank you.
Okay, thanks, Ali. Phil?
Yeah, these are very difficult questions. I suppose the first point from Joe about the existing health and wellbeing partnerships, I suppose what I think the role of the health and wellbeing boards in every area are being asked to do is to draw out a plan for the future. And the start of that's got to be, well, what have we got going on already? What's the existing partnerships and services and collaborations and so on that are happening? And then looking at that and then saying, well, what's missing from that? Where do we want to go in the future? And I think this is where the Health and Wellbeing Board has been given a role to play, a specific duty to try and do that task. So I don't know your area, Councillor Ross. I don't know, sorry, Joe, I don't know enough about it, but it feels to me as if it's not been done yet, or if people have kind of ignored a whole part of the landscape that exists, then that's the thing to focus on. The relationships between those people who are not doing that, who are not recognising that, and making sure that they do. And I might add, I think in some of these partnerships, I would add the voluntary sector often gets kind of overlooked. And this is partly a change of culture for everyone. For people in local government, I think this is less of a change of culture because they're used to think in a place-based way. For many people in the NHS, this is a different way of thinking about their job and their role, thinking about the environment that people live in. We heard Alison's point about thinking about the whole family, as opposed to thinking about, an organ or a disease or a condition or a waiting time type thing that drives the way the NHS behaves. So there's a bit of cultural kind of connectivity and sharing and learning from each other. And there's lots you can learn, obviously, from the NHS about how it goes about doing its things in a very kind of structured way, with thinking about the triangle of need and so on, which all provides. So I think it's about maybe the opportunities that the Neighbourhood Health Service gives you is the opportunity to think in this more holistic way, and to do so, you've got a vehicle for making it happen that bring together the health and the local government elements together through the Health and Wellbeing Board work. So that would be a sort of map what's going on, and if they're missing bits off the map, why is that bit missing off the map? Who's not listening to whom? Why aren't we working better together? I was thinking about what Ian's just said. The collective approach. I suppose I go back to some stuff I used to do in government, using the old Cotter theory of change, which is if you found something which is a burning deck of problems and you needed more than one person in the room to sort out that problem, then get the right people in the room. That's a holistic approach. Think about the various aspects of, I'm thinking here about maybe the health and well-being of a particular cohort of people in the community or a particular estate, and say, right, well, what are all the causes of these issues, and how do we collectively have a vision for what the future might look like, and then collectively have a mandate from the very senior people in all the organizations to say, we will now collaborate in doing this. And if you find a middle manager who's not doing it, or a frontline worker, let's feed it back up to that group of leaders who are going to take a particular focus, and then, as it were, like do a worked example of how holistic thinking actually works. Because once people have done it, suddenly they, well, we did it over there for that group. Well, we might as well. Why don't we do that for that group over there? And just a final point. No one's mentioned education very much. I think Alison did a bit, but I do think on the children front, where schools play a role in neighbourhood health services has not been thought through that I can see. And I think there is a job of work to do to really bring in the teachers and the head teachers and the people, because that's where kids are. That's where families stand outside the school gate. There's so many things that could be done on that front that I think needs to be highlighted as we go forward. So I've just chucked in something extra there, Chair. My apologies.
Thanks, Phil. Yeah, and I think Joe's point about language and it's acronym city. And I still find a lot of it baffling in terms of acronym city. Ian, did you want to come back on?
Only just to very briefly say, I think we all agree it's about the partnerships and about the skills and about relationships. Unfortunately, obviously, and I say that from this perspective, and I'll put it in the chat, is about with local government reorganisation, with the ICB changes, the reduction in funding for the ICBs, I have a real fear that those relationships will be lost and actually will end up navel gazing about our own structures and people worrying about their jobs, rather than about the task of bringing the most deprived area out of it, reducing the suicide rates and all the many other myriad of things which the brilliant partnerships are doing at the moment. And the risk is that will get lost.
And there's lots of rural areas, that share those same issues, Ian, which is one of the important things. I noticed there's some questions in the chat, so if anyone wants to actually put their questions, please feel free to do so. So you want to raise your hand and ask a question? Or I can look in the chat and do it for you.
I can see one that mentions my name, Richard. Aligning
a good question mentioning your name
with Pride in Place boards.
Right.
Now, I think this is something where, frankly, the left hand and the right hand of government have not been talking to each other. We talk about being holistic. So whilst people have had a very good kind of shared idea of what neighbourhood is about and place and the importance of doing it, they've then gone off and done their own thing, and you've ended up with the Pride in Place with neighbourhood boards, and you've ended up with neighbourhood health services, which will have some kind of, and health and wellbeing boards sort of leading the development of those. So I think this is where at a local level, so I do some work, try to influence central government so that they don't have that kind of two great ideas colliding, as opposed to good theory kind of emerging together into a coherent way. But at a local level, and you've heard it from some of the speakers earlier, then it's up to the local people to say, right, how do we kind of put these two together? How can we combine our neighbourhood board that's Pride in Place and its purposes and goals and the funding we get from that with the neighbourhood health services, and make sense of that at a local, in our patch that suits our priorities and our goals and our population. So do I have specific ways that they've done that? I think we heard one earlier from one of the contributors about how that's being done, and I think it's, frankly, it's less for councillors here. This is about officers. I think it's you guys who've got to sort of say, right, we've got all these different streams coming in. How can we cleverly use them? To be honest, I think the Better Care Fund was an example of it not working very well. I think it just became a kind of icing on the top for a particular group of services or even just to subsidise the social care budget because it was struggling in some areas. So I think there are things we know what not to do, and I'm keen to see examples and then to share examples through the Health Devolution Commission and other things I connect with, where people have put together these different funding streams and priorities that have come out of different parts of government and made sense of them in an integrated way, in a holistic way locally.
Rory and Piers, have you got anything to contribute on that Pride of Place idea from your real?
I'm happy to pick up a conversation with Beth offline. As I mentioned, I think Greenstead is a pride in place location, as well as being a focus for our neighbourhood health work. And as Phil said, we're bringing that together. Because our neighbourhood health thinking has always been embedded in looking at the lived experience of people in Greenstead, and really looking at the kind of assets and the wider determinants. It's a natural fit. We'd already invested in the infrastructure that's described. Now there's the clear synergy with the kind of indicative spend that government have set out that you can allocate pride and place funding to, which also supports the kind of scaffolding, whether it be infrastructure through investment in building, but also interventions in a community. I think the key thing, both in terms of our neighbourhood health work and the pride and place, is around it being community led. The pride in place actually gives us an opportunity in Greenstead to really sustain our work. And the funding obviously helps, but to continue the journey we've had. So we see it as a continuum rather than something that's working in parallel.
Okay. Ali, Piers, do you want to
can I just say one other thing about the word pride? I think it's quite interesting. I don't think the NHS they're proud of the NHS. What we're saying is be proud of the place in which you're providing those NHS services, and and we know how pride and hope go together very often. I'm proud of being, when I was an MP, I was proud of my town, which was Corby. I was proud of my ward when I was a councillor, because you are there representing and trying to do right for them. And I think that word of pride could be used very powerfully in these partnerships for the NHS to see the sheer value that brings to communities, to feel proud of the place there. And if they don't, then bloody well get on with it and turn it around to make it a place you can be proud of. And I think that this is the cultural shift I think that we want to see on both sides of the health and local government equation.
And that's also, again, in terms of our experience at Malden, it's also that element in terms of the mental part, and doing those things which create a community and create that engagement. Piers, Ali, do you have any on that?
I think Phil describes that very well.
Okay.
I think I just wanted to say that for some of our local communities, while we've done a lot of focus work on Harwich, Colchester and Clacton, we have other New Garden towns and villages developing, and there's a real opportunity to really embed this from the beginning and to think about that in a different way, because we won't know the populations that are coming. But again, it's how do callers on the call, but also locally, how do we really think about that work together to make neighbourhoods embedded from the start there, and place thinking, but also some of our hidden communities. How do we really begin to think about neighbourhoods and that approach, and taking pride and having hope from the beginning? So it's something we're really cognizant of in North East Essex as a whole, that we could do better in and we want to do better in. Thank you.
Yeah, it's that crucial thing. Are we building housing estates, or are we building communities?
Yes.
Yeah, and we need to build communities. That's the crucial thing. If we don't build communities, I live in a village. If we don't create the same sort of identity in communities in these new places we're creating, it will have huge mental health issues as a starting point. But that's my 2 pence. Are there any other questions that anybody's got at all? We've got a couple of minutes left. And hopefully everybody's contributed into the chat in terms of the topic.
Could I ask a question, Richard?
Yeah, of course you can, Phil.
No, I was intrigued by the example of the social impact bond, or the sort of funding, and the that idea that there might be a community interest company, that there might be funding, and then the funding gets repaid if you achieve success. And I had an attempt to try and do this some years ago, and found it very difficult to squeeze £1 out of the NHS, if I'm honest with you, to then to make the saving, to make a saving in a hospital bed is quite hard to do, and for that money then to go into the prevention. And I'm just wanted to ask how well that was going, and whether was it too early days to say yet? Because I like the model, but found it really hard to get people to sign up to it.
Well, Ros has put her hand up to
Ros,
because she was part of the team that put it together.
Yeah, so we're not actually measuring outcomes for the first 6 months because we recognise it takes time. That is the purpose of this, that it's a multi-year investment model. This works because the hospital is on the hook for repaying the grant into the KIC. And so it has been developed over a lot of time in designing the approach and getting all the partners on board, but it has been driven by the Acute Trust, and I think that is absolutely critical to making this work. I think there's also recognition that at the beginning, certainly there's going to be a lot of cost avoidance rather than cash releasing savings, and you have to be really clear about what the counterfactual actually is, because we're operating against a period of growth in the baseline.
Yeah, it's about shifting that perspective, isn't it?
Yeah, that's very helpful, and I'm very familiar with all the what the counterfactual should be and how you measure them, and then the moving feast of it all, and how you attribute causality within that to say that it was us that did this. Therefore, yeah. So I'll be intrigued to keep in touch with that, Richard. I must say, I think everyone should, because if it works, it is a way of shifting resources around the system. I said at the beginning that the shift from hospital to community has to be a shift of resources as well as it were services. Otherwise, you're just putting more burden onto the community and to carers and all that. So finding mechanisms to do that is a really important part of this process. So that's very helpful. Thank you.
Okay. There doesn't seem to be any more hands up. So thank you all very much for attending this morning, and thanks for the positive feedback we've been getting in the chat. There are more LGE events coming up, so please make sure you're aware of those. I'd like to thank Kate and Matt from the LGE for facilitating and creating this event today, and for the way the LGE supports groups across, not only local authorities, but different groups across the area. I'd like to thank Piers, Rory, Ali and Phil for their excellent contributions today, and thank you very much for spending the time to come and present. Thanks very much.